it's more effective than pure diphenhydramine. Do you think that's the reason? Because I got very nice, good sleep with the Germans, but not the one pure diphenhydramine.
I'm not sure about the diphenhydramine, but of course it's an antihistamine. It definitely, as part of its side effect profile, it actually does help with sleep induction. It's just that the study here is they're showing that the olfactory nerve is very active. That's why you have moments that when you're sleeping and you smell fire, you wake up. That's because anything that is that you can smell still triggers more of these stimulus, even though you thought everything's shutting down during sleep stages. But yeah, use that at your disposal. You're getting treatments while you're sleeping, and it's even more if people want to like do more things and be more proactive about everything. So diffusers are really good.
Great.
Mhm.
I think we are going to the lecture, right, Doctor?
Going to the lecture. All
All
right,
right. So
Halasa, do you
I'm
need
Dr. Halasa.
you need
You want to
introduce?
go introduce, or I'll go introduce myself?
I guess not. Okay, go
Go
ahead.
ahead, introduce me.
Here's Dr. Halasa.
Hi, I'm Dr.
Here's-
It's yours, man. Go ahead.
No, you go ahead. We're good to go.
No, no, go ahead.
You're our fearless leader, right? So
Hi, I'm Dr. Halasa, the founder of Chronic Disease Prevention and Management, and I think today we're going to talk about how we are outperforming oncologists in managing cancer. I'm talking about everybody here who are integrative doctors. You do have the skills and the education and this experience to really outperform the oncologists because oncologists did fail in managing cancer. And by the way, Stefan, the video that I loaded did not they there's it's still there on YouTube, so it's not being um, put down. So we're good. Even this video, if we put it up, it's going to be okay. Um, So in order for us to know exactly how we are better than the oncologist in managing cancer, we need to know what's the failure, how the oncologists fail in managing cancer, what's going on with the chemotherapy and radiotherapy and things that the mainstream medicine is doing. So does that mean we're gonna ditch what they're doing and just do integrative medicine? No, we're gonna use what they're doing, but we're gonna do it in a smart way. So we don't ditch the weapons that's being done. We're going to perfect it and improve it, which is the chemotherapy and radiotherapy and all and immunotherapy that the mainstream medicine is doing. But also, we're going to navigate managing cancer, not just killing the cancer. And that's what most of the mainstream medicine or oncologists are focusing on, just killing the cancer, which is it's okay, but as long as you're not killing the immune system and you're not killing the mitochondria. Because if you kill the mitochondria and you destroy the mitochondria, then you're losing the mitophagy, which is one of the way that we can get rid from cancer. And also, if you get rid from the immune system and you destroy it, then definitely you are losing the weapon, the intrinsic weapon, your endogenous weapon to kill the cancer. So as long as you are killing the cancer, at the same time, you are changing the tumor microenvironment to be a hostile environment for the cancer, and you're empowering the immune system and polarizing it to Th1 and cytotoxic T cells, which is to CD8, and you are empowering the mitochondria, then we are in a good position to say we can do better than the mainstream medicine. And also, the mainstream medicine, they use high dose of chemotherapy that's toxic, and it goes everywhere, which toxicate the cancer plus your healthy tissue and your immune system and your mitochondria. So it's better if we can learn how to target those chemotherapy into the cancer using nanoparticles, using platelets nanoparticles, or using exosome derived from stem cells, whether it's umbilical or from your patient's stem cells. And I can help you. I can train you to load drugs inside platelets nanoparticle. The big pharma is already doing it, one in California, but it takes them 10 to 20 years to pass through all the regulations. We can do it today. Today we can go, and I already trained around 10 doctors to load drugs inside platelets nanoparticle. And again, you can also load inside exosomes. Um, so that's the lecture of today, basically. And as you see, the picture here just shows you that how the CDM protocol outperformed convention and by a systemic biology strategy to reverse cancer resistance. And because of chemotherapy, if you see how it's been approved, it's been approved based on the data from the population, which is they come up with a trial, and 50% of those patients have remission, but other 50% not necessary to have remission, and that's okay. If 50% have the remission, we can approve the drug. The other 50%, what happened to them? Well, those other 50%, they may be genetically cannot metabolize those chemotherapy. It's not effective because of mutation in the cancer. And in fact, if you give those chemotherapy cocktail to those patients, you may actually speed the process of or shorten the lifespan of the patient. And in fact, maybe not taking the chemotherapy, they can stay longer, living longer than taking it. So that's a difference. So we, as integrative oncologist or chronic disease prevention management specialist, we take the circulating tumor cells from the patient or from biopsy from the cancer. And we use drug sensitivity testing, same like we do with bacteria. You take the bacteria sample from the blood or from the urine, and you do drug sensitivity for it, for antibiotics. It's called pharmacogenetics for antibiotics. We can do the same thing for cancer. Now, the question is that whether it's reliable or not, why we don't have it here in the United States. Those labs, most of them are international. The FDA are skeptic with their results. And the other thing is that one of the pitfall that this methodology is, if we end up sending those samples, which is biopsy or blood samples, which contain circulating tumor cells, DNA, send it to the lab, and you come up with a list of the drugs and supplements and peptides that they are sensitive to, and you say, okay, those are drugs, is a peptide, but the problem is that those cancer can mutate. Even with the one that is being sensitive to today, maybe after one week or 2 weeks, they become resistant to it. So that's the problem where the FDA is being skeptic, but having something better than not having anything. So still, it has a position, and it does help us to narrow down at least the most probable drugs and supplements and peptide that the cancer will be sensitive to. So that is the difference. And also in conventional oncology, as you see, those chemotherapy and radiotherapy do destroy the immune system, and they destroy the mitochondria. Especially if you destroy the mitochondria, what you end up with acidosis. Why? Because the way that the cancer or even your normal cells get rid from the lactic acid buildup from glycolytics, glycolysis pathway, is to be shuttled in the mitochondria. And if the mitochondria is being damaged by the chemotherapy, so those lactic acid will be pumped out into the extracellular space of the cancer, so it become acidic, and that acidic itself will cause the immune system to polarize into Tregs instead of Th1 and cytotoxic T cells, and those Tregs will form a shield around the cancer. And also, this damaging effect of the chemotherapy, it may lead to causing inflammation, but not the good inflammation, actually the Th17 mediated inflammation. And the cancer itself would secrete chemistry that polarize the immune system away from cytotoxic T cells, which is to Th2 and Th17. And that leads to increased interleukin 6. And interleukin 6 can lead to coagulation or increase the coagulability of the blood, and that leads to forming platelets and fibrins around the cancer. In addition to that, the cancer secretes transforming growth factor beta and interleukin 10, which leads to stimulation of fibrosis. And the chemotherapy does enhance that, especially damage the mitochondria, leading to extracellular tumor microenvironment to be acidic. That itself is polarizing the immune system away from Th1. And so what we need is to inhibit the glycolytic metabolism, whether by using the keto diet or by using drugs that inhibit the glycolytic and activate the mitochondria. Because this mitochondria, it's a ticking bomb inside the cancer cells, and the cancer is secreting chemicals to inhibit it. And along with that, you have the chemotherapy is destroying it. And we can do things to help to revive those mitochondria and revive the mitophagy, which will lead to blowing up those cancer cells. So that's the reason I think our approach is more comprehensive, and it's more uh, effective, because we are not just killing the cancer only, but also we are looking to change the tumor microenvironment so it become a hostile environment, because those cancer cells, they secrete chemicals to make the tumor microenvironment in favor of the cancer. Like they secrete chemicals like interleukin 10 and transforming growth factor, which leads to fibrosis, and the fibrosis itself squeeze the blood vessels, and the blood vessels become kinky, and preventing the infiltration of the lymphocytes and the red blood cells. And when you prevent the infiltration of lymphocytes and the red blood cells carrying the oxygen, right? So those cancers, although it's highly vascular because they do secrete vascular endothelial growth factors, right? Those cancers. But the problem is that they're highly vascular but hypoxic. And people would say, how is that? Well, they have a lot of blood vessels, but they're kinked. They're being squeezed by the fibrosis. So what would happen if you have your house hose is being kinked? You may end up having the plasma passing through, but all those big particles like red blood cells and white blood cells cannot pass through. And that's how the cancer is doing, is shielding the lymphocyte from infiltrating the cancer, and also shielding red blood cells. Now, what's the problem with shielding red blood cells? If you shield the red blood cells, that means you're shielding out the oxygen from going inside the cancer, right? Um, and so what will be the solution here? Well, the solution is to break those fibroses and also inhibit those excessive vascular endothelial growth factors. So you normalize the blood vessels, and you can do that with losartan and clotho, or you can do that with focusing ultrasound. Photodynamic therapy may help as well. That the light therapy does cause some increase in the blood flow. Um, but also, I mean, you can eventually. The other problem that we have is the red blood cells, when it's being squeezed out, the oxygen cannot go in. So what we need now to do is to find a way that we can get the oxygen even without red blood cells. So how we can do that? We give them ozone. Ozone will dissolve into the plasma, and this will carry the oxygen into the cancer. So that's one way. Or you do the oxygen chamber and things like that to help to increase the plasma concentration of oxygen. So that's another way to bypass the hypoxic effect of the cancer. So there's many tricks. The cancer is doing its own tricks. We need to learn the tricks of the cancer. It's an enemy. And in order for us to win the battle with cancer, we need to learn about all the tricks of the cancer, right? You need to know about how your tactics of your enemies in order to win them. Of course, the mainstream medicine have no clue about this. I mean, basically, all their focus is how to kill the cancer. And when they use the chemotherapy, they are targeting certain protein or certain enzyme or certain genes or certain receptors. But the problem with that, the cancer is smart. They will mutate. And if they mutate into another cancer cell lines, that cancer drug will not work anymore, right? And ultimately, whether it's radiotherapy or chemotherapy, the ultimate effect of inducing apoptosis is free radicals, right? And free radicals needs oxygen. So I have a problem with those oncologists when they will say, "Oh, yeah, integrative doctor, please don't give ozone or oxygen to the patient who is receiving chemotherapy or radiotherapy because it will interfere with our work." Well, that's not true, because chemotherapy cannot work without enough of oxygen. Because the ultimate effect of chemotherapy and radiotherapy is to generate free radicals. And if you don't have enough of oxygen going to the cancer, your chemotherapy and your radiotherapy is not going to work. So that's how you answer those people who are having problem with adding integrative medicine. At the same time, they are using the chemotherapy or radiotherapy or the mainstream medicine protocol. So that's the difference between us. We still use the chemotherapy, but we will use it smartly. We will do the pharmacogenetics and come up with the list of drugs and supplements and peptides that is sensitive for that specific cancer. And also, we're not going to use a toxic dose. We're going to use 10 to 25% of that dose and load it inside platelet nanoparticle. And when you load inside platelet nanoparticle and you get that package the size of up to 100 nanometer, um, you will have more tendency to be filtering those package into the cancer tissue versus healthy tissue. Why? Because the cancer tissue, their blood vessels is leaky. So they will allow those sizes to go in, but the healthy tissue are very tight. They will not allow up to 100 nanometer to be passed through. The question is that, is there already chemotherapy that's being done in the form of liposomes? Yes, Doxil is a chemotherapy drug that's coming from doxorubicin. Doxorubicin is a naked drug, and most of the oncologists, they move into Doxil. Why? Because it's a liposomes in the range of 18 nanometer, and they load the doxorubicin inside it with the concept of nanomedicine will help to deliver drugs passively into the cancer versus into the healthy tissue because of the blood vessels of the cancer. It's more leaky. The blood vessels is more tight. But where's the problem there? The problem is that the macrophages does intercept them, especially in liver and in the lung. They see liposomes still synthetic, so they intercept them. But they say, well, we can stop that and inhibit the macrophage from eating those nanoparticles by giving a drug. It's the chloroquine. Last night I mentioned a drug that's wrong, chloramphenicol. So hopefully the video last night will be recorrected. It's a chloroquine, which should help the macrophage from eating, you know. But there is a publication that has been done where they made a study using doxorubicin, Doxil, which is loaded with liposomes, and doxorubicin loaded with platelet nanoparticle from the patient. And the platelet nanoparticle loaded doxorubicin was more effective than Doxil and doxorubicin. So that's what we are entertaining. And the reason why, because the platelets works like a torsion. The body, the macrophage will see it as itself, so they will not intercept it. And so you can get more drug concentrated into the cancer, whether it's in the brain or in other area, without being intercepted. So you don't need to add chloroquine for this regimen. So that's the summary of what we're going to present tonight. And I will go through those slides. But if is anybody here has any questions up to now, because I like to have the lecture to be more interactive, making sure that we are all on the same page here. And there will be a clinical case at the end of the slides. But I will go through those slides easily now because now we have the what you will be expecting from me now. I think I just summarized it in 10 minutes. But if there's anybody, before I go through those slides very fast, if you have any questions, go ahead. So you
Dr.
can keep it
Halasa, I have a
entertaining.
question.
Yes.
The chloroquine, hydroxychloroquine, you're talking about autophagy inhibition? Is this what you're talking about? And during chemo,
Yeah, it does help to prevent the macrophage from intercepting nanoparticles. That's been
Gotcha. Okay.
published in one of the nanomedicine in University of Florida somewhere. They have that, but we don't need it. If you do platelet nanoparticle, they are endogenous, so it works like a torsion. We solved that problem, so we don't need the hydroxychloroquine. But hydroxychloroquine is still good for cancer, along with ivermectin and methylene blue, because they inhibit the Th17, and that's what you need because the cancer is secreting chemicals that polarize the immune system to Th17 and Th2 when you want it to move it to Th1. So anything that helps the Th17 and Th2 it's good for cancer, whether you're using antihistamine or that inhibit the Th2 or using any drugs that inhibit the Th17 like hydroxychloroquine and ivermectin and methylene blue and thymosin alpha. Those are inhibitors and helps to modulate the immune system. So you still can use it for cancer. It's not a bad thing to do. And in addition to probiotics, which inhibit the Th17, the butyric acid that the probiotics and postbiotics and and the probiotics are secreting. Does that make sense? We're good?
Yeah.
Any
You.
question? Everybody's happy here before we go through those slides very fast? Because I think I gave you the kind of the butter. Dr. Dario, you good?
We're all
Dr.
doing good. No
Halasa,
questions yet on my end.
Dr. Halasa,
Dr. Patel, how are you?
how are you?
She's one
Good,
of
good.
the top doctors in integrative oncology, by the way, and she's She's doing the loading of platelets, so she's very, I think she's happy. Are you happy, Dr. Patel?
Yes, of course, I do. I do it for many other things uh, besides the use of the oncology for
Right.
cancer medicine. You were mentioning about TH17 and inhibiting. Um, I just wanted to bring. We should not forget the low dose naltrexone. It does the same thing. So
Yes. Not that done anything and have the net TH17 would definitely help the
yeah,
cancer all the
that's
way.
right.
Or
That's right.
inhibiting TH2 as well, or inhibiting the Tregs.
Just that
Uh,
whole thing. Yeah.
right. The Tregs, the best thing for that is the antibody, anti-PD-L1 and anti-CTL4. The immune oncologists, they're happy, excited about it, and I'm happy, excited about it. But the problem with if you inject it nakedly, goes everywhere, you end up having autoimmune diseases and colitis, which will drain the immune system again. And so loading inside platelets, nanoparticles, those antibodies, getting into the cancer versus going everywhere, it's the best option for even for the anti-PD-L1 and anti-CTL4 that the immune oncologists are doing. So we are doing better than them because we are targeting the drug and we use 10 to 20%, up to 25% if you want to go with max of immunotherapy or a big pharma products. And we, as I said, we change the tumor microenvironment to be a hostile environment for the cancer as much as we can. Is that good? So let's go through the slides. So conventional oncology still relies heavily on population-based protocols. Basically their cocktails are based on the clinical trials, 50%, 60%, 70% have remission. The others, we don't care. It's good. Just move it, approve it. What about those 30%? They still have taking it. When we don't know who are 30, from the 30% of 50. It's going to be a chance. It's like flipping a coin. And sometimes the chemotherapy can really shorten the lifespan of the patients, especially if they have resistance to it. Radiation. So I think radiation can be more better if we have radiosensitive drugs being um, given to the patient. Some chemotherapy, they are radiosensitive, like cisplatin, and you give cisplatin with radiotherapy, but you try to make the dose of radiotherapy lower, and you target the cisplatin with platelet nanoparticle. I think you can get better results than just blasting the patient with radiation. And so the chemotherapy, the oncologists, they have this mindset of single target agents, and the reason they have that because the big pharma is controlling it, and they don't like to, even in their clinical trials, they don't combine things. It has to be mono. And the reason it's going to be monotherapy is so that they can approve it through the FDA. So really, it's the protocols, the clinical trials are not really based on what's best for the patient. Because if what's best for patients, you will look for trials where they combine many things, where those many things help to navigate the side effects of certain things and empower and enhance the efficacy of that specific chemotherapy. They don't do that because this will make the clinical trial. They don't even know. Then they will end up not knowing which the drug is effective, which not. So they approve only immunotherapy. So we need to come up with protocols that is supported by not companies but by the government, that is combined, that looks for the best interest of the patient, not to approve the monotherapy. Big pharma can continue doing that, but before they shift it to the patient, we need to come up with some clinical trials that combine many drugs that's been approved and funded by the government, because nobody's going to fund it. Okay. There's no money if the funding for multi-therapy protocols, and that's the reason we are behind the curve. And that's why the reason why international doctors are more successful, because they have this physician autonomy where they can combine things without being scrutinized. Here we can't. Those oncologists, if they don't follow the strict rules of the big pharma and the CEO, um, their license will be threatened. So there is no physician autonomy here, and that was RFK. We hopefully that he will budge in here and help to restore the physician autonomy, where we are doing what's best for the patients. We're still going to use your big pharma products, but we're going to use it wisely and combined with other things and without the interference of the big pharma. Um, So often ignoring individual variability in drug metabolism. They don't really care about the pharmacogenetics of the drug. They have a cocktail drug. Okay, this is good for squamous cell carcinoma of the skin. Okay, here's the cocktail. And that's it. Everybody has absolutely. They may have some alternative cocktail, switching to it, but it's not, the switch is not based on the pharmacogenetic of the patient. It's based on this one failed. Let's go ahead to the second round. We're going to do the other cocktail. Okay. And the other thing is that the problem with the chemotherapy, they have the highest dose, right? So they have a period of time where they can do the medication. Let's say 3 months and twice a week. Okay. But after that, you cannot do anymore. The reason why, because if they do any more extra or extend that, it actually will cause suppression of the immune system, which will cause the cancer to flourish and growth, and it will make the cancer more worse. And that's the reason say, oh, the chemotherapy say, okay, we give him the course, we cannot do it again. He has to wait for 1 year to get that. Or same thing for radiotherapy. They have to wait for 1 year to get another sessions of radiotherapy. Because already the body is being depleted, the immune system is being depleted. Any extra chemotherapy, anything, you will end up destroying the patient. And us as integrative oncology, we're using the low dose and we're targeting it, and we're using all this integrative therapy that helps to boost the immune system and the mitochondria. So we are safe of giving unlimited of our dosage and treatment until we get rid from the cancer. And it's more dynamic versus the oncologists. They are more static. So variability in drug metabolism, mitochondrial health, and immune function. As we say, we are modulating the immune system to be polarized into Th1, not just by the immunotherapy that the big pharma is doing, which we're using it too, but we're using it with loaded and not toxic dose, but also with other supplements and repurposing drugs that we are using, including thymosin alpha and things that inhibit the Th17 and have the fibrosis, and have the excessive vascularization that leads to abnormal blood vessels that easily kinked, which will eventually prevent the infiltration of the lymphocytes and the red blood cells and the oxygen and lead to hypoxia. Important to know. In cancer, they say, oh, it's highly vascular. So how it's hypoxic. Well, it's hypoxic because they're kinked. They don't allow the red blood cells to carry the oxygen in. And now we learn why the ozone people, they're doing very good. And they're happy. Oh, I treated the cancer. I did the ozone. But the problem with us integrative doctors is that they maybe treat one case and third, and they say, okay, everything is ozone, everything is oxygen, everything it's photodynamic therapy. Listen, I had this mistake too. I was ignorant. I was thinking photodynamic therapy is the everything, and then ozone and photodynamic therapy is everything. Now, me and my group, which is the 10 doctors that we are the same page here, we know the cancer is very intelligent, and we don't think this is the only thing. It's an onion with many layers, and we're peeling those layers, and we all the time think that the cancer is finding another tricks. And I am asking you if there is other tricks than the tricks that we are mentioning here about the cancer. Please let me know, because I don't put myself that I am the expertise. Anybody say I'm the expertise, I'm everything in cancer, he's a fool. Because this cancer is a very intelligent creature. He's a very intelligent enemy. And I want to learn, and we all want to learn all the tricks. And I don't think we can get to all the tricks, but we are learning. Once we have a complete solutions and cancer is completely wiped from the universe, then at that time I will say, yes, we are winner. But if there's one patient who die from cancer, I think we still loser. But still, even if you add 1 day for the patient's life, it's still better than nothing. The CDPM, Chronic Disease Prevention and Management, which is a medical specialty that I'm entertaining. I'm hoping I can get to the RFK, and because he's also interested in chronic disease, where to become a board medical specialty. American Medical Association is entertaining this field of medicine. I'm providing CME for many organizations, including this one, and this is CME, and we have the link for it. We have actually 2 links. You can use any links of those. And you can go ahead and get your 2 CME. Even for international doctors, they can get the CME. from American Medical Association. They just need to translate that certificate into their country board, medical board. So you talk to a medical board, hey, we got this certificate. Can we translate it to our board? And they will. Most of American CME are translatable to your country medical board. So a next generation framework that integrate cancer pharmacogenetics. This is what we do. Redox signaling. Yes, we modulate the redox. We do the photodynamic therapy where we give the photosensitizers, we load inside nanoparticles of cyclodextrin, and we inject it to the body, and those will concentrate the cancer. And then we shine the light on the cancer to activate those photosensitizers and react with oxygen, generate free radicals to induce apoptosis. And immune modulation, we polarize the immune system to Th1, inhibit the Th2 and Th17. So we're doing all that. Also, chemotherapy. A lot of chemotherapy that do have photosensitive. They are photosensitive as well. Let's say cisplatin, they are photosensitive to around 200, 300 nanometer. Doxorubicin, I think in the red light, they're sensitive, same like methylene blue, 650. Um, and so we can give the chemotherapy and activate them with light. And so generate free radicals. This will empower and enhance the efficacy of those chemotherapy. There's a publication about the low dose photoactivated chemotherapy in one of the university in California. They have a nice publication on that. And we're using low dose. So it's not a toxic dose, and we load a cyclates nanoparticle, and we concentrate it into the cancer versus going everywhere. And you can use it unlimited until you get rid from the cancer. And you activate it with light. So you are generating free radicals just by the photosensitizer. In addition to that, chemotherapy interfere with the metabolism, which will eventually lead to increase the free radicals, which will lead to apoptosis. All the chemotherapy, radiotherapy eventually will lead to increase the free radicals because that's the only way you can induce apoptosis. So we are amplifying the effect of the chemotherapy with light. Again, you can use focusing ultrasound to break down the fibrosis and lowering the infiltration of the lymphocytes and the red blood cells carrying the oxygen. That's one another way. Or you can use photoablation as well. And if we are working with the compounding pharmacies to load drugs inside cyclodextrin. I have a pharmacy who's doing it, and at the end of the CME, I may mention their name. Right now I can't, but we are working on getting all the injectables, cyclodextrin, at cyclodextrin loaded drugs, whether it's peptide or chemotherapy, whatever. It's it's better than any drug that's naked because it stays longer. It targets the pathology. It absorbs better, especially when you're using six hormones. But also you can use it for chemotherapy. And then once you take this encapsulated cyclodextrin, you can go ahead and still you need to do the plates nanoparticle. So you make it bigger size, the size of up to 100 nanometers, so you can get this passive infiltration or targeting of the cancer. By applying personalized genetic, metabolic, and mitochondrial, very important. We definitely help to regain the function of the mitochondria that's being lost. Being lost by the cancer is secreting chemicals that inhibit the mitochondria because the cancer is very smart. Let's say, hey, this is a ticking bomb. We need to stop it, inhibit it. But then how they get the energy, we can use glycolysis. Now, the problem with glycolysis is the buildup of lactic acid, and lactic acid is going to be toxic to the cancer. The cancer is smart. What they do, they increase the expression of pumping the hydrogen outside the cells. Okay? So they pump out the hydrogen outside the cells. Okay, this would keep the cancer pH buffered. What about the outside? It will be acidic, which is good for the cancer because acidic environment helps to do things. One, it will help to polarize the immune system into Treg, which will cause a protective shield against the cancer. Second, it will help the acidity of the extracellular environment helps to de-differentiate cancer cells to cancer stem cells. And cancer stem cells, it's very difficult to get rid from because they behave like normal cells. They have enough of antioxidant machinery that neutralize the free radicals that induce apoptosis. So they're very resistant because, they have this antioxidant will neutralize, same like in normal cells. And so Do we have the strategy to inhibit the cancer stem cells? Yes, there's a lot of unique pathway in cancer stem cells, which we're going to talk about in coming slides that we may inhibit. Plus, doing the immunotherapy may help. Plus, reactivating the mitochondria and changing the tumor microenvironment to alkaline to prevent the differentiation to stem cells and also differentiate them. Once they turn into alkaline environment, they will differentiate. And when they differentiate, you can get rid from it. So it's we have the tricks, or we know the tricks of this cancer, and we have the counter measurements on counter effect. Um, and so we improve the mitochondria profiling. The CDMM protocols offer safe, smarter, more effective cancer therapy with durable remission potential. So conventional oncology did fail. It's population-based protocols, and it's fixed cocktails. Some people are sensitive, some people are not. It's based on chemotherapy. We know the chemotherapy, radiotherapy damage the mitochondria, damage the immune system, which is something we don't want. But we're still going to use it, but we're going to use it in a smart way. We're going to use low dose chemotherapy for photoactivate with light, which is being published in one of California University, more effective than the high dose chemotherapy. And radiation, if you want to do it, try to do radiosensitive chemotherapy loaded with side nanoparticles and still use the radiotherapy. But while you're doing that, you need to give the patient ozone. You need to give them thymosin alpha. You need to polarize the immune system to Th1. You make sure the tumor microenvironment is alkaline. Now, I have a problem with those doctors about the alkaline and also the way they are teaching it. They think, okay, alkaline, go ahead and drink alkaline water. All right, that's not how it's going to work. Because if you drink alkaline water, where it goes? It goes to stomach and the acid of the stomach, and that's it. You're done. It neutralizes it. There's no effect there. Um, or they will say, we are drinking alkaline food. Okay, alkaline food is not the food has a pH of alkaline. That's the misunderstanding. And then a lot of oncologists, they become big and famous for the mispresentation of alkaline and acidity. What we're changing is the alkalinity and the acidity of the tumor microenvironment. And you cannot do it by drinking pH, alkaline pH food or drinks. Okay. But what meant to be alkaline food is a food like polyphenols, a food that activate the mitochondria. Once you activate the mitochondria, you will be shuttling the lactic acid to the Krebs cycle and to the oxidation phosphorylation, and you burn it and you get rid from the building up of the pyruvic acid or the lactic acid. That is the alkaline food. So alkaline food is the food that helps to inhibit the glycolytic pathways. Yes, keto diet, for example, because low sugar means less glycolysis, or drugs that inhibit directly the glycolysis, or drugs that inhibit the mitochondria. But it's not like, okay, the alkaline food or drinks is the pH dipping into the pH, and if it's alkaline, that's good for the cancer. If it's acidic, like orange juice is not good because it's acidic, so it's not good for the cancer. No, no, no. That's where the problem is. And some oncologists, they integrative oncologists, they present it that way, and it's completely has nothing to do with with uh, with the chemistry of what we are looking for. Um, and then the FDA will go after those doctors, and then doctors, they don't have an explanation. That's the problem. But as long as you're explaining, my YouTube, even the one that I have, and Stefan said, "Oh, it's being censored." No, it's not. It's there, and I don't think I have any YouTube that's been censored up to now. And the reason, because those people who are listening to my lectures, and hopefully to your lectures as well, try to back up your lectures with chemistry, because the people who are watching those YouTubes are PhD, they're not clinicians. And the clinicians, sometimes they don't explain the chemistry just because they have this practical, and they say that's justification. But those PhD on the monitor there, they want chemistry. So once you explain the chemistry, I believe nobody, will argue chemistry. So the other thing about the conventional, they are single target agent. They target enzyme or receptor, but those receptors and enzymes, they can mutate. And if they mutate, it's done. That chemotherapy will not work anymore. Okay. So, we're going to see in this coming slide the importance of bypassing the those resistance and how we bypass it. We're going to see that in the coming slide. So CDBM protocol is based on cancer pharmacogenetics. It also modulates the redox in a way it will increase the redox into the cancer, so it will induce apoptosis and kill the cancer. It's immune modulation by polarizing the immune system to Th1 and CD8. We use for the dynamic therapy to generate enough free radicals to induce apoptosis in the cancer. And we use, very important, advanced delivery system like cyclodextrin and platelet nanoparticle to get those medication to the cancer versus going everywhere. Still, we can use chemotherapy. So that's the difference between savvy integrative doctors who say, "Oh, no chemotherapy, no immunotherapy. We want to do only supplements." Oh, no, that's not medicine. We are doctors. What we learn from our books, whether it's vaccines or chemotherapy, we're going to use it. We're going to use smart. If the vaccine is not effective or it's not thing, we're going to say, "Oh, we like a vaccine, but COVID vaccine is not uh, it's not as effective." But we need the COVID vaccine, one that's effective, the one that has not, it's immunogenic and it's not pathogenic. But if you give me an immunogenic vaccine, it's a pathogenic, it defeat the purpose, or it give you a unbalanced immune system, they defeat the purpose. So it's very important that when you present, okay, I'm with vaccine. Who does not want to prime your immune system against the enemy? Yeah, everybody wants to prime the immune system. So we are all, as integrative doctors, especially my group, we all want vaccine, but we want a vaccine that is immunogenic and non-pathogenic. And immunogenic that gives you balanced immune system, that gives you enough of Th1 memory, not immunogenic, give me Th2 memories and Th17, and it gives you neutrophils when it's facing an antibodies without cytotoxic T cells. And I have a book on that being published in Amazon. You click my name in Amazon, you will find out 5 books. One of them is the immunological insight of COVID, which shows that we want the vaccine, but we wanted to have the vaccine that's balanced and non-pathogenic. Personalized. So CDPM is protocol of CDPM is based on personalized genetics, metabolic, mitochondrial profiling, providing safer, smarter cancer therapy with, of course, durable remission. Now let's go through the those slides very fast because I think I just mentioned everything here. What's the limitation of conventional oncology? The limitation that we have so it's very important to know what is the pitfall of the weapons that we have and how we can improve it. Don't ditch it. I mean, some savvy integrative doctors say, "Oh no, I don't want to do chemotherapy at all." No, no. Those weapons, they are like those blind bombs, chemotherapy, immunotherapy. Yes. Well, we can go ahead and engineer them and make it to be more smart bombs. Would they be selectively getting into the target without collaterals? So we're going to still use them, but we're going to use them smart. So I don't want to upset the big pharma here. So they will hear my lecture here and they will say, "Okay, Dr. Halas, you're using our products." Yeah, I'm going to still use your product. I'm still promoting it, but we're going to promote it in a smart way. Okay. So in chemotherapy, the mainstream strategy, non-selective cytotoxicity, right? To get toxic to everything and to the cancer. We want to be cytotoxic to the cancer, but not to the healthy. Can we do that? Yes. By loading those drugs inside nanoparticles. That's one. Right? You package them. So that's the difference. And we make them smart and then the platelets itself. See, it's exactly like a targeting bombs, right? Those targeting rockets where they have the satellites that seize and attach. Well, the same thing for those chemotherapy. We're gonna load them into platelet nanoparticle. And platelet nanoparticle will be in the size that's up to 80 nanometer that tend to infiltrate or seeps through the junctions that's open, that's leaky for the cancer tissue versus the healthy tissue. That's passive targeting. What about active targeting? The active targeting, platelets itself, naturally, they have receptors on their surface, platelets membrane, which is the platelets nanoparticle that's being packed with the drugs. They have naturally receptors that target the cancer cells, that target the infective cells, the inflamed cells, the senescent cells. So that's the good thing about platelets nanoparticles. So we're not using it just for cancer, but we're using it for all the applications. That's what Dr. Patel said. I'm not using it for cancer only. I'm using it for immune. I'm using it for infection. I'm using it for everything. All her injectable is a load of platelets nanoparticles because that's smart. Okay, that's she's one of the smartest doctors, by the way, in this entire universe because she's like a sponge. She have her own things. She adding it to it, but she doesn't have the ego and absorb it. I have Dr. Joseph James, the same thing. Dr. William Clearfield, I learned from him a lot. Dr. Naryu, Dr. I got his name. Okay, I got mental block. From Africa. What's his name?
Tano?
Tano. Dr. Tanner, one of those are top doctors, by the way, in this group. And I'm hoping that me and Dr. William Clearfield, when we get the number of 100 people here attending, and we may join forces to develop a physical meetings but at 39 is not enough. So if you want to help us to create a physical meeting for and join force with Dr. William Clearfield, and put it, we need 100. So how we get the 100 is you, 39, if you can invite 3 and 4 every time you come here and you feel this is your room, like I'm doing on Monday. I have my Monday show. But I have less than Dr. William. I have only 20. He's getting 40 and 50. I'm jealous. But I'm gonna steal Dr. Milvin Naryu. I think that's the doctor who's bringing a lot of international doctors. So,
No,
Dr. William Clearfield, can we trade? Can I pay you on the table and
no,
get Melvin Naryu in my room?
absolutely not.
All right.
No,
So
I'm keeping Dr. Nario, I'm keeping Dr. Quinn, and I'm keeping Dr. Tano.
no, Quinn is mine. There, no question.
Dr.
Agnario, it's
Dr.
yours. But
Tano.
origin, Quinn, I worked with him almost. We've been knowing each other 10 years. He's the one who developed, by the way, the first indocyanine green nanoparticle. When I was trying to, he passed away, his wife, with ovarian cancer. We did all this photodynamic therapy using Dr. Weber's methylene blue, and we did all that. But on with those photosensitizers, they absorb red light, so the light does not get into deeper. So we need to find and photosensitizers that absorb the infrared, so infrared goes deep. And so that's how they in Arabic language they say الحاجة تكمن الاختراع أو الاختراع تكمن الحاجة, means that the demand is the mother of the discovery. And so I end up I have to find an FDA approved drug that is photosensitive to the infrared. And let me just a little bit see the dark. Oh yeah, I have my son, Dr. Clearfield knows it. I know about my son. He's knocking the door, he's making a little bit noise. But anyway, so and this is part of the lecture, by the way, that this story that I'm going to mention here. So Dr. Quinn, I told him, hey, I find a drug that's indocyanine green that absorb infrared and it's FDA approved, but we don't find there's no human studies. It's only for rats and mice. But Dr. Quinn said, no problem. As long as it's FDA approved the drug, we can do it. And he did it, and he made it. But his wife passed away, so during the process, they took this idea from him because he shipped to them, and he's calling me all the time, call Dr. Quinn. We need this product. We need this product. And Dr. Quinn, he shut down his pharmacy at that time for some reasons. And much of people know it's all about the politics and all that. But anyway, so he ended up doing it in Germany, and he sold this bias for $4,000, and he made very good business out of it. But again, it's also very effective in terms of, and then you go after that, you can see a lot of publications on indocyanine green on human use. So we can say the German did trigger the whole thing. Maybe we started, but the Germans are the one who end up all the colleges and universities because they did it published in university in Germany, and then the US copy it. It was the same thing for Methylene Blue. Methylene Blue was not in Amazon. All those Methylene Blue was, and I came up, me and another pharmacist, to use it for COVID, and it works very well. And after that, the whole publications, like hundreds, and Amazon is full of Methylene Blue. Even RFK himself is admitting taking Methylene Blue for COVID. So it starts here. Don't think that it's a small group. Yes, but innovations can start with this small group and it become big, especially with Dr. William Clearfield. I mean, come on, this guy is the most intelligent DO ever met in this planet, along with Naryu and Tano
Those
and
guys are
also.
MDs. They don't count.
No. Let's say Dr. Stefan Hartman. Okay, he's a PA, physician assistant, and his protocols and way that he is treating the patient may be the best among all of us, including myself, because he is implementing the chronic disease prevention management protocol in the right way. He has a gym along with his treatment, and that's what you do when chronic disease. If you don't have a gym, you don't have the cryotherapy, you don't have the sauna, you're missing a lot in optimizing the health of the body. So, Dr. Stefan, I consider him one of the pioneers. And so the titles does not mean much for me, whether you're MD or DO or PA. What meant for me is the outcome and what you're doing and what you're presenting. And especially here, I am in asking you to become more critic and review everything I say here, and I need your opinions, whether it's negative or positive. Negative is sometimes good because it helps us to direct us in the right direction, and I don't get offended. I like that. I like the debates, and that's how the science evolve. Most of the lectures, that's not in two ways. It's spreading misinformation because it's one angle. Here, I have no problem. If you say I'm wrong, correct me, and I will appreciate and I will say thank you. But that's what we do in our meetings, whether it's on Monday or Tuesday. So the mainstream strategy, there are non-selective cytotoxic. It's like blind bombs. Radiation therapy, ionizing, cell destruction, they rely on free radicals as well, by the way. And those chemotherapy, radiotherapy will not work without enough of oxygen. So if the cancer is hypoxic, you're not, those chemotherapy and it's not going to work. So you really need to have ozone. So what you're doing as integrative doctors, you're really supporting those mainstream medicine for their drugs to work. And any mainstream medicine, if they told you about, hey, don't use ozone, all that stuff, it's interfering with my protocol and all that stuff. Now you can explain it to him. You say, well, chemotherapy, radiotherapy depend on oxygen. And the tumor is smart enough. He's stopping that from getting into the tissue. So we're helping to bypass it by dissolving the oxygen into the plasma. Or you can take platelets nanoparticle uh, and infuse it with ozone, and then you give it to the patient with IV. The other thing is that the chemotherapy or mainstream medicine protocol is targeted agents. When those agents were receptors or enzymes or proteins, if they mutate, you're done. The chemotherapy is not going to work anymore, and the cancer start laughing at you back. So other thing, those targeting could be the EGFR, epithelial growth factor. We have inhibitors for those receptors, or the HER2 or estrogen receptor or progesterone receptor, tamoxifen, all that stuff. Those are targeting receptors, but they can mutate. And if they mutate, it's not going to work. The other thing that mainstream medicine does, the immunotherapy, I'm very thankful for the PD-L1 and PD-1, anti-PD-L1 and anti-PD-1 and anti-PD-L1 and anti-CTL4 antibodies. But the problem with them is that they may help to inhibit the Tregs around the cancer, which is something good to polarize the immune system Th1. That's what the immunotherapy does. But at the same time, you can do it everywhere in other part of the tissue, leading to immune sensitivity of your own self tissue, which leads to colitis and all the side effects of immunotherapy, which will drain the immune system, and you get back into the problem of draining immune system and draining exhausting the polarization to Th1 because they start busy moving it to Th17. That's the reason immunotherapy needs to be loaded inside platelets nanoparticle, and then you give it to the patient, and that's where we are different. So this is the problems of the chemotherapy. The other thing is that the multi-drug resistance, those drugs that patients is receiving, easily can get resistance because they mutate. The ABC transporters, those transporters of chemotherapy, the cancer is having receptors. They express receptors to kick out the chemotherapy from their body. They're very smart, very intelligent. They just having increasing the receptors that pushes out or kicks out the chemotherapy. Same like the bacteria, when they get resistance, they have transporters that kicks out antibiotics. Now, how we can solve this problem? Okay, so think about it. If the membrane has receptor transporters or shuttles that kicks out the chemotherapy out, right? Okay, but if I use this chemotherapy and I package inside a platelets nanoparticle, which is a membrane, and throw endocytosis, which I'm taking portion of the membrane of that tumor to get it around that nanoparticle, right? So what would happen to those shuttles that's in the membrane, the vesicles of endocytic vesicles? They will be actually pushing the drugs from inside the vesicles into inside the cancer. So those transporters, they will be kicking the drug from inside the platelet nanoparticle that's endocytic inside the cancer into the cancer, right? That's how we can override the resistance, and we can do that with antibiotics by loading those drugs inside platelet nanoparticles or cyclodextrin, where they are taking it by endocytosis. Then those shuttles, they will be shuttling the drugs from inside the vesicle into the cancer cell, which is something that we want to concentrate the cancer, chemotherapy into the cancer. So that's how we override this, or we use drugs that inhibit those transporters, but they will mutate. So the best option is to load them inside platelets nanoparticles. The challenge is high toxicity, frequent hospitalization. Yes, they get this immune suppression and then infection and all this things that the suppression of the bone marrow and red blood cells low, and they end up with platelets low and bleeding and all the problems with toxic chemotherapy. Lack of personalization, that's what's happening. So now we are learning what's the problem with our weapons that we're using against cancer. It's lack of personalization, so it's like a blind bombs, dosing and drug selections, nothing, they don't do the pharmacogenetics, and they're using the high dose. Neglect of tumor microenvironment. Have you seen any mainstream medicine say about tumor microenvironment and changing it, inhibiting changing the environment to alkaline, polarized immune system to Th1, inhibiting Treg? None. Mitochondria. Chemotherapy, radiotherapy destroys the mitochondria. And that is very important because mitochondria is one way to kill the cancer by mitophagy, right? And redox function, also we balance it because we know the importance of the normal redox and also polarizing the redox so you generate free radicals, especially when we do photodynamic therapy to induce apoptosis in the cancer. Static statement protocol. Those protocols are static, they're not dynamic, they're not responsive to real-time patients' biology, versus what we do is really we are reversing and studying all those problems, all the weakness of the mainstream oncology's weapons, and we're making it perfect, and we navigate all the side effects and all the pitfalls there with the strategies that we are using in integrative medicine, whether it's polarizing the immune system to Th1 and CD8, or activating the mitochondria, or using targeting therapy, which is the delivery technology like platelet nanoparticle to bypass those resistance. So the CDPM, a systemic biology and pharmacological approach. The CDPM protocol views cancer as biological adaptive multi-axis disease. Yes, very important to know that people say, oh, the cancer is just a metabolic disease. It's a chronic disease. It's not genetic. And they have no clue. Anybody say cancer is metabolic or just immune dysfunction? No, it's all. It's immune dysfunction. It's metabolic. It's genetic, it's environmental toxins, all of this coalesce, and if they all add together to the point, then you will end up triggering the cancer, especially when you are challenging the immune surveillance. And you can do that just by psychological stress, by increasing the cortisones, right? Most of the people having cancer, they have traumatic event that leads to constant high cortisone. Cortisone suppresses the cytotoxic T cells, interfere with the immune surveillance, and that leads to the emerging of the cancer, right? But then we'll say, okay, well, someone will come and say, well, my father smoked all his life and he died at 100. Another one will say, well, my father smoked and did not smoke and he died from lung cancer. And the other one who smoked, he did not die and he passed away at age of 100. The one that he did not smoke, the one that smoked did not die to the age of 100, and the one that did not smoke, he died, for example, at the age of 40, 50. So, and people who are smoking, they say, hey, I'm 90 years old and I have no problem with my lung. And my friend, and of course, with that smoking, his voice has changed. He has cancer and he did not smoke and he died at the age of 50. Yes, it's because they're genetics. And that person had genetic problems that lead to the cancer. But that seems like one who smoke, he has very powerful genetics. He's very good genetically. He's able to detox and so. But if you have both problem with genetics plus problem with environment, then you have high risk of having cancer than anybody else. So, in other words, it's a combination of immune dysfunction, redox imbalance, mitochondrial suppression, metabolic reprogramming, and the tumor microenvironment acidification and fibrosis. And so, what about patients with obesity and metabolic syndrome? Yes, obesity and metabolic syndrome leads to mast cell activation syndrome, and it can lead to high cortisone, and the cortisone high can interfere with the immune surveillance, and they put you at high risk of cancer. So yes, obesity is one risk factor indirectly that can lead to cancer. The fat tissue also stores all those fat soluble toxins, which most of them they are tumorigenic. And yes, so patient with obese, they do have high risk of having cancer because of the metabolic syndrome, that leads to mast cell activation syndrome, leads to cortisone dominancy, and leads to acidosis and all that stuff. May lead to mitochondrial dysfunction. All of this together, if he has some genetics there, then those patients, they may have a high risk of having cancer. So health optimization is very important. Now, the question is that what is the risk of having cancer throughout your lifespan? Do you know how much? It's around 1 to 2 to 1 to 3. It's like a flip of the coin. That's how much the risk. In the graves, one among 6 of those people that you see them in the graves and the graveyards died from cancer. And the risk of having cancer throughout your lifespan is 1 to 2, 1 to 3. Some studies 1 to 2, some studies 1 to 3. That's a lot. And I think because of that, we need to come out with an insurance, start when the age of 18, where we pay $100 per month, so that when we have cancer, we have at least insurance pays, because in order to defeat cancer, you need to have at least $10,000 per month. Less than that, don't think about it. And all this Concenair 2 weeks and 3 weeks, that's a joke. Really, cancer, you need to work on it till you destroy it. And in order to do that, with all the supplements and all the drugs and everything that you're going to give to the patient and all the time and all that stuff, it's a lot and a lot of cost. So if we start with insurance, maybe from the government or from private, where they say cancer insurance, where they start collecting $100 per person and maybe some government support there, then we have enough money. So when the patient, which is 1 to 2, having a risk of cancer, they would have enough funds so we can do all of this. Because all these things that we are talking about, it costs money. And I think that's what the direction. Maybe we can reach out to RFK and tell them, this is an eminent risk of people dying from cancer, and they don't have the money to back it up. And I think it's good to have something like this. And also, in addition to that, we need to work on insurance that will cover prevention and health optimization. In Japan, do you know that? Um, in order to you to be qualified to be in employment at government or even private, they measure your abdominal circumference, and if it's above the normal, right, you're not qualified. You're not getting a job. This is how much they are interested in preventive medicine, and that's kind of a way to push patient or people to optimize their health and not just eating like we have here in the United States, 60%, 70% with obesity, which most of those obese patients, they do have some sort of chronic diseases as well. So the chronic disease prevention management protocol view cancer as biological adaptive multi-axis diseases. It is a combination of genetics, immune dysfunction, redox, mitochondrial, metabolic, and tumor microenvironment. Okay, we're good with time. We still have another 40 minutes. It has to be 2 cm hours, so we have here to 10. Um, and hopefully you're not sleeping, guys. But if you have any questions, go ahead. I don't want the one-way lecturing. If there is anybody wants to entertain us with something, go ahead. Everybody's okay here? You're not sleeping? Are you enjoying it? I don't know. Am I still online?
Keep going.
All right. So the mechanism of cancer resistance and CDPM counter strategies. So now we are going to learn about the tricks of cancer. This cancer is tricking us. The problem: cancer cell overexpress ATP binding cassettes, which are transporters that expel the chemotherapy drugs, leading to multi-drug resistance. So they express those receptors to kick out the chemotherapy from inside the cancer cells, right? That's the same thing that bacteria does when they are resisting to antibiotics. So what we will do, well, if we pack the drug inside the platelet nanoparticle and we bypass that by pushing the drug inside the cells by endocytosis, then those membrane who has the transporters now, where they're going to kick? They're going to kick the drugs from the inside of the vesicle into the tumor, which is good. All right, does it make sense? Do you imagine it? In fact, this will be a good thing. So all we need to do is just go ahead, take those drugs, load inside place nanoparticle, use endocytosis, and you can bypass this problem. The other ones is that we have drugs that inhibit those key transporters. They're out there, and that's what we do. But I think the platelet nanoparticle will be the good option that we can do. Along with, you can use ACGC that helps to inhibit some expression of those transporters. But use the decreases the expression of those transporters. But again, when you have the drug is moving to endocytosis, those transporters, in fact, they will concentrate the drug into the tumor. They will kick the drugs from the inside of vesicle into the tumor, which is something that we favor. So that's the solution that the chemotherapy we have the problem with, which is just one way of resistance. Tumors survive genotoxic take the stress by upregulation DNA repair and pathway. So we're trying to kill them, but they are trying to survive. So they have a lot of mechanism of repairing when we are trying to destroy the DNA by interfering with their metabolism or by radiotherapy. They end up fixing those DNA by expressing those enzymes that repair those double DNA stranded and all that stuff. So we can go ahead and give them chemicals or drugs or supplements that helps to inhibit those repair, and that possibly leads to the killing of the cancer. So that's one way of doing it, which is inhibiting those repair enzyme that repairs those DNA. And there are many inhibitors, PARP inhibitors, which is the olaparib is one drug that blocks the single strand repair. So, including synthetic lethality and BRCA mutated tumors. Checkpoint and kinase inhibitors also, we can use it to inhibit those repair enzymes that is trying to prevent those cancers from dying. Um, or we can enhance the free radicals more. How we can generate more free radicals to overcome the repair, because what's destroying those DNA is the free radicals. So we give them ozone, we give them NAD, we give them photodynamic therapy, methylene blue. All of this helps to overwhelm the repair machinery of the cancer. And you can see that in illustration here very clearly about how the cancer is upgrading or they are upregulating the expression of those repair enzymes like the BRCA. And one way of doing it is to overwhelm them by concentrating in the tumor those photosensitizers, shine with light, and generate too much of free radicals where they cannot repair it anymore. That's, they cannot, they will overwhelm the repair mechanism, or we go and give them drugs that inhibit the repair. I prefer photodynamic therapy and low dose chemotherapy activate with light over inhibiting the repair mechanism, because possibly those repair mechanism is going to be also for the normal tissues. And so just do low dose chemotherapy photoactivate with light along with photosensitizers. But if you think that this will help, just go ahead. But think about it, if they're inhibiting the repair, unless those repair mechanism or pathway, it's unique for the cancer, it's not going to be affecting the healthy tissue, then it's okay. Or you load those drugs inside plates nanoparticle and cyclodextrin so you can move those drugs into the cancer versus going everywhere. So that's another option that you can do. Make sure all your drugs is loaded cyclodextrin nanoparticles so you don't affect the repair mechanism of the normal tissue. Now, the problem also what the cancer is doing, so the tricks, we're learning the enemy, the strategy of the enemy, so we can defeat it and destroy it and kill it. Cancer cells evade programming cell death, right? Whether by the B cell lymphoma and which inhibit the mitochondria, right? Mitochondria is responsible for mitophagy and killing the cancer cells. So what the cancer does is secrete chemicals that inhibit the mitochondria, because mitochondria is a bomb, ticking bomb that will induce mitophagy. So the cancer is smart, intelligent, expressing those pathways to inhibit the mitochondria, stop the mitochondria from working, and stopping the mitophagy. Plus, doing that, you end up with building up acid, which is lactic acid, but the tumor is smart, will pump those lactic acid into the extracellular environment to keep this tumor pH buffered. But the extracellular tumor environment that's acidic is going to be in favor of the cancer because it will polarize the immune system to Treg, plus it will de-differentiate the cancer cells to stem cells. What are the things the tumor does? It's mutating the p53. P53, we know it's the enzyme that triggered apoptosis, and they mutate it so they don't die, and they start dividing continually. Now, what we would do here, we will introduce the p53 through umbilical exosomes. That's one way. Or we look at the way to activate the p53. So tumor suppressor genes is often mutated or degraded via this mouse double minus 2, minute 2 or minus 2. So CDPM solution, you use venetoclax and inhibits the BCL1. That's one way, and reactivate the mitochondrial apoptosis. Or you use the Nutlin 3, blocks the MDM2 and restore the functional p53. That's one. Or you can go ahead and give umbilical exosome, which contain healthy p53 that may be introduced inside the cancer and induce apoptosis. Again, if you use exosomes, try to use the exosome in a way that it's like poisoning or killing a rat or mice in your house, right? So what you do, exosomes, they do tend to concentrate in the cancer, by the way, but also they have some growth factors there. So it's like a sword with two edges. They have PA53, which is good for cancer, but also they have growth factors. So what I will do, I will load those exosomes with chemotherapy and photosensitizers and AMPK activators or MMT inhibitors, and then pack it with those poisons. So when the cancer is taking them, it will help to favor the destruction versus the growth. The other thing is that you can do to induce apoptosis is to give photodynamic therapy or low dose photoactivated chemotherapy, which will generate enough oxygen and free radicals that will push the apoptosis and overwhelm the tricks of your cancer. Okay. Warburg metabolism and tumor acidosis. So as we know that the cancer itself secretes chemicals to inhibit the mitochondria. When you inhibit the mitochondria, you're inhibiting the oxidation phosphorylation, and you're inhibiting the Krebs cycle, and you're inhibiting the breaking down of the lactic acid. So lactic acid will go with pyruvic acid. So pyruvic acid will be turned to lactic acid, be kicked out of the tumor cells, and turn the tumor into acidic microenvironment. And we know the acidic microenvironment is in favor of the cancer because it'll turn the immune system into Treg, which protect the cancer, and also de-differentiate the cancer cells to cancer stem cells. So how we can override this, or how we can counter this? Well, we can do it by low sugar keto diet, because you have low sugar, low glucose, you have less glycolysis, right? That's one way. Or we give them drugs that inhibit the glycolysis, or we give them drugs that activate the mitochondria. And when you activate the mitochondria, you are burning the pyruvic acid into CO2 and water in a state of turning into lactic acid. So all those things that we can do. And of course, the cancer is secreting all those chemicals to boost the glycolysis and inhibit the oxidation phosphorylation. Like they are upregulating the monocarboxylase transporters, which will kick the lactic acid and protons outside the cells, which is definitely turns the tumor microenvironment acidic, which in favor of the cancer growth. Or they increase the expression of carbonic anhydrase, which will turn the pyruvic acid to lactic acid. Or they increase the expression of vacuolar type ATPase, vacuolar type APTS, which helps to pump the hydrogen out, the proton out. So what you do, you give a drug that inhibit the pyruvate dehydrogenase kinase, which converts the pyruvate into lactic acid, restore the pyruvate dehydrogenase, which breaks down the pyruvates and getting inside the mitochondria to be burned, activates the mitochondrial oxidation, or you use polyphenols like quercetin, ECGC, curcumin. All of this helps to activate the mitochondria or inhibit the glycolysis and lactic export by those polyphenols. I'm not that in favor of saying drinking sodium bicarbonate. Maybe IV sodium bicarbonate, maybe that's good, but you know the blood has ability to buffer them. Unless you're injecting it into the tumor, I don't know about sodium bicarbonate. I'm not in favor of that, nor I'm in favor of proton pump, unless the proton pump works on the cancer cells itself. Then that's good. But if it's thinking about proton pump in the stomach, no. But if they work in the cancer cells and they inhibit the pumping of hydrogen into the extracellular environment, I'm in favor of that. And I need Naryu to investigate this more if you can, because Naryu, I think, is going to pick up on all these things and make it even better. I know he's very smart. He reminds me about Dr. Joseph James. He all the time able to make even things more better, right? But I want you, Dr. Neri, if you can investigate about the proton pump inhibitors, because I don't know about if it's gonna inhibit the acidity in the stomach, it's not gonna do much. But if it's gonna inhibit the tumor cells from pumping hydrogen ion, I think it's okay. Neutralizing cellular acidity, ketogenic diet, fasting. Oh, fasting is very important, right? I think fasting is a religious thing, whether you're Christian or Jews or Muslim. I think fasting and all the religious they do sort of fasting, by the way, which will reduce the glucose fuel supply. And I like the fasting to be 12 hours apart, like taking breakfast and then don't do snacks. I'm not. If we do all of that, we don't do snacks, so that we can keep the 12 hours where we can activate the AMPK and inhibit the mTOR and induce autophagy of the senescent cells, cancer cells, and inflammasomes containing cells. Okay, so I think we already talked about this picture, right? You see it there? Very clear, okay. Now, one other trick of the cancer is they secrete chemicals. They secrete transforming growth factor beta, interleukin 10, which leads to fibrosis. Oh, the fibrosis is a very damn thing. My dad passed away from hypopharyngeal carcinoma, and when he did the radiotherapy, he did shrink the cancer, and he starts swallowing, but it shrinked, but it's not eliminating. And when he did the CT scan, you can see that there's a little spot uh, in his throat, in his pharyngeal, like a little lamp, that's indicated there's glycolysis, and uh, because the PET scan is basically radioactive glucose, right? So you can see it's a little lamp in his PET scan, which indicate that this tumor. Okay, so but when I tried with him doing photodynamic therapy. At that time, I don't know much. It's like 5 years ago. No. Maybe in the 5 years from now, we will know better than now, right? Especially with Nadu and Tano here and Dr. William Clearfield. They will take all of this and scrutinize and make it even better. So in 5 years, going to be this kind of thing is going to be a big thing, and it's going to be in the mainstream practice, hopefully. But that's what if we join forces, right? Then we drop the ego between us, and we start putting our hands and cheering each other that we can take this to the next level. And I'm surrounded by smart people. Those my team, and we are friends and buddy by the way. So what happened is that when I saw that, and I was kind of turned off. And when we took him to Germany, even the dynamic therapy is not working. The methylene blue is not staining that cancer, right? So what happened when they did the radiotherapy and chemotherapy? We got rid from um, all the daughter cancer cells, which is the differentiated cancer cells, but they end up because of the chemotherapy and radiotherapy. Well, he did not do much of chemotherapy because he has heart failure, so that's one of the problem. But he did radiotherapy, and what happened is that the cancer cells are so smart, they are secreting chemicals, especially when you block the mitochondria and you turn the environment to acidic. And the acidic environment leads to polarization of the immune system to Treg, but also to Th2, by the way, and Th17, which leads to increase the fibrosis. And the fibrosis, and the cancer itself secretes all this. When they get threatened, they start secreting transforming growth factor beta. And the fibrosis, along with turning those cancer cells into stem cells, so you have 10 cells and fibrotic shields, and the fibrotic itself can protect the cancer from the radiation, right? They take the hits like a shield, and they're hiding inside this little shield of it's like a spiral shield of fibrosis, right? And they're hiding inside it. And those fibrosis, what they do, they squeeze the blood vessels and preventing the infiltration of the red blood cells, which carry oxygen, and the lymphocyte infiltration. And they stay there hibernated for the time when they have radiation. So it's kind of way to protect themselves. And once the course of radiation is done, everything is done, then they start dividing and growing and expanding even more worse than because they become more resistant to all those things that we're doing. And especially cancer stem cells, they behave like normal cells. They have antioxidant machinery, same like normal cells, so they can neutralize those free radicals, and they have very good repair mechanism. And so even when you do methylene blue and all that stuff, it's not staining, it's not getting there as we wanted, and that's the reason it's failing. And at that time, I don't know about those things. I don't know about breaking the fibrosis using focusing ultrasound, or giving losartan, or giving glotho, or giving even nattokinase. Bromelain nattokinase. It's not just breaking down the fibrin of the clotting factors, so the fibrin. No, it also breaks the fibrosis, by the way, the nattokinase. So I have no clue about these things. If I know, I think I may be able to break this fibrosis, open up those blood vessels, allowing the infiltration of red blood cells and the lymphocytes. But that's what happened. It's ignorance of that we don't know, and now we know. And I think after 5 years, we will know even better, right? So that's what's happening to cancer. They do fibrosis. They increase the blood. They increase the vascular endothelial growth factors, and this leads to fibrosis, leads to a growth of blood vessels, but they're kinked, And that's the problem. And those cancers will be protected with the fibrosis and it become hypoxic. So what we can do now, we need to go ahead and reverse that, right? By giving bromelain, nitrokinase, cytokinase, which helps to degrade both the fibrotic matrix and the fibrin. Those cancer cells also secrete interleukin 6 because of activation of Th17. And interleukin 6 leads to activation of the clotting, and they become more coagulable, and they form fibrin and platelets. And those fibrin and platelets also protecting the cancer, same way like fibrosis. And that's the reason giving a low-dose aspirin will be something good, but nattokinase, streptokinase will do both. Will break down the fibrin and the fibrosis. And you can use Clotho. You can also use Losartan. Also, it's good to bypass that squeezing of blood vessels by dissolving more oxygen to the blood using ozone, oxygen chamber. And all of this may help in and eventually and using platelet nanoparticles loaded with drugs. That is one way to help as well, getting it inside the cancer. And you can infuse those platelet nanoparticle with oxygen as well. All right, so we're good with this. Okay, so let's go with another way that cancer works, and we still have 15 minutes. The other way that the cancer works is by polarizing the immune system away from cytotoxic T cells and the Th1. They secrete all those chemicals, especially transforming growth factor beta, interleukin 10, into vascular endothelial growth factors. All of this helps to polarize the immune system, along with the tumor inhibit the mitochondria, leading to extracellular acidosis. Acidosis leads to favor the polarization into Treg and Th2 and Th17 away from Th1. So what we would do, mainstream medicine, they came up with immuno-oncology drugs or immuno-oncologist drug or immunotherapy drug, which is anti-PD-L1 and anti-CTL4, which will help to uh, to prevent inhibition of the naive T cells and turning into Tregs. So if you do those antibodies, if they attach to PD-1 or PD-L1, it will prevent the inhibition effect of the cancer cells with Tregs. So when the cancer cells is being facing with the T cells, after it's being presented by the macrophages, right, as you see it there, the PD-1 will lead to inhibition or polarization of those naive Tregs into naive T cells into Tregs, and you have a lot of Tregs forming a shield protecting the cancer. So if you block it, then what will happen when the antigen presenting cells is presenting those things or to the cancer, to the naive T cells, they will polarize into Th1, and that helps to kill the cancer. So that's how we can override or this challenge that the cancer is doing, which is expressing those PD-1s that leads to shutting down the naive T cells and turning into Tregs. If we block them with antibodies, then they will not be shut down and they will polarize into cytotoxic T cells, which will help to kill those cancers. And those antibodies, if you give them nakedly, it may lead to colitis and autoimmune, and normal tissue become insensitive, and you break the immune tolerance with it. So the best option is to load them inside platelet nanoparticles, anti-PD-L1, anti-CTL4, and anti-PD-1s, which is the Nivolumab. This is one example. Or you can use supplements. Also helps in inhibiting Tregs, like curcumin, ACGC, and resveratrol. Or you use butyric acids from the probiotics and postbiotics that would inhibit the Th17, polarize the immune system to Th1, or you empower the redox signaling, which will help to break down those tumor cells, ozone and NATH, and this may help to enhance the antigen presentation by breaking down and enhance the cytotoxicity of the cytotoxic T lymphocytes against the cancer. All right, so There's a lot of way to polarize the immune system to Th1, whether antibodies or supplements or probiotics. They inhibit the Th2 or any other drugs that inhibit the Th2 and Th17, like ivermectin does inhibit the Th17, plus ivermectin does inhibit some signaling, especially for cancer stem cells. By the way, ivermectin is a good thing for cancer stem cells because they do inhibit some signaling of cancer stem cells, which is another challenge that the cancer is using to trick us, or in other words, to protect himself against our weapons. They polarize, or they differentiate into cancer stem cells, and those cancer cells, they behave like normal cells in terms of they have enough of antioxidant machinery that neutralize the free radicals, and they become quiescent and hybrided sometimes, and then and they spread too. They divide and spread and all that stuff. Yes, but they are very resistant. So what we will do, we will find out is any unique pathways that specifically for cancer stem cells that we can block. Yes, the WNT, the Notch signaling, the HH, all of those signaling pathway, we can inhibit them using some drugs, polyphenols can be doing that along with metformin and selenomycin, plus other drugs that's under investigation that can inhibit those pathways. In addition, if we work on everything that we talked about, modulating the redox and activating the mitochondria and the immune polarization and activating cytotoxic T cells, all of this will help, and turning the tumor microenvironment from acidic to alkaline, which will help to differentiate those cancer cells into differentiated one, which was easily you can get rid from them. All of this together, we may end up winning the battle against the cancer tricks. So cancer is like a magician, and you need to know all the tricks in order to expose him. Otherwise, he will definitely end up winning at the end of the day. So we want to be more smarter than the cancer. And to do that, we need to kind of knowing all the tricks of the cancer. The other thing we do is to take photosensitizers that is sensitive to certain wavelengths of light, like methylene blue is sensitized to 650 or 670 nanometer. We load the site plates nanoparticle, we inject it to the body, they concentrate the cancer, and then we radiate the cancer with light. It activates those photosensitizers, generate enough free radicals that will induce apoptosis and kill the cancer. But we can use that for chemotherapy. Doxorubicin, for example, they absorb the red light as well, and will help with low-density nanoparticle, and we can inject them, so we can benefit from the action of doxorubicin in blocking certain pathway in the cancer, but also in generating free radicals. So this will enhance and boost the efficacy of the chemotherapy, and we use beta nanoparticle to help in concentrating those drugs and supplements or those photosensitizers into the cancer. So that's one way of, but again, in combination of everything, we can definitely win the battle here. So again, very important, those drugs and supplements and peptides, whatever we use, it needs to be specific for that cancer. So how we do that, we take biopsy from the cancer, or we take the blood sample, circulating tumor cells, we send it to the RGCC lab or other labs, and there's not much in the United States. The reason why, because the FDA is still skeptics about the results, and because of the cancer is changing. So those cocktail of drugs may work now, but will not work after 10 days or 1 day. Or things, but it's a good thing still, because you still narrow down the drugs and supplement that we think it's going to work, and then we can enhance. Even if they have drug resistance, we're smart, we can overcome that by loading inside place nanoparticle. So yeah, they may develop resistance, that's fine, but we're doing it with latest nanoparticle here, and possibly this, along with other things, we can override the resistance. The FDA have no clue about that. We are smart enough to even oversmart those cancer resistant pathway. But it's better than just giving chemotherapy cocktail without testing it against the cancer sensitivity. So that is the pharmacogenetics. I have clinical cases, but it seems like, okay, I have a clinical case, and it seems like when I load it here is not the one. And the time, I think it's 10 minutes. I promise next Monday, if you want clinical cases, either Dr. William will give me another time. I can give you 8 cases. If that will enough for 2 hours, case per 15 minutes. Or you can come next Monday in my show and I will go ahead with 8 cases. It seems like I loaded the wrong one. Otherwise, there was a clinical case at the end of it. Because I think time is over and people are sleeping here and they have a lot of questions. So let's do that in the next meeting, whether in Monday or Tuesday. Is that good, Dr. William?
Yep. That sounds
All
good.
right.
Okay.
Okay. Any questions?
Okay. Thank you so much, Dr. Halasa. Let's see. Study in rats exposed gamma radiation shows that nanokinase 720 FU kilograms per day exhibited antioxidant effects, reducing MDA and lactate dehydrogenase. This suggests a potential protective role against radiation-induced lung injury. That the findings are preclinical. Okay. Okay. So, Dr. Nario, you have anything online?
I
Oh, I
do,
was
but
just
there's.
answering that. Oh, sorry. I was
Oh, go ahead.
answering
Go
that question. Somebody asked if they could do nattokinase while they're on radiation therapy. Somebody asked that in the chat, so I was answering them. Sorry.
Yes, yes, because they're even better. Because you want to break the fibrosis. You can do nattokinase, you can do ozone, you can do oxygen. You don't want to reduce it glutathione, anything that's reduced, because you want to have some free radicals and you want to navigate that, negate that. You can give NAD as oxidized NAD, but not NADH. That's fine too. You can give ozone, oxygen, but when we go to the clinical cases, which is next week, Monday or Tuesday, depend on the schedule of Dr. William or my Monday, I will commit to put it in for 8 cases. We will see live cases that is being, the whole program is being applied into a clinical case, which will give you better understanding and visualizing what we're doing. And the nattokinase is not just to break the fibrin, which we think that's only for clotting factor, but also for fibrosis. So what's good, especially with atherosclerosis, atherosclerosis, it's 3 things. There is plaques of fat, oxidized LDL inside the macrophages, which needs to be cleared by cyclodextrin. But also there's calcium deposit, which needs to be cleared by EDTA. And also there's fibrosis, which needs to be given nattokinase. So when you treat atherosclerosis, it's better if you load cyclodextrin with the EDTA, which you can do it with the compounding pharmacy. And hopefully we can stop the recording so we can talk about other things. Can you do that, Dr. William, so we can